Hello everyone. Let's talk about scoliosis today. Scoliosis is a lateral curvature of the spine with vertebral rotation. So this scoliosis is usually non-painful unless it is very much advanced or the curve is really bad. And this curve can be present anywhere in the spine, like in a cervical area, thoracic area, lumbar area, and you may also see that it is usually you may see a secondary compensatory curve in the opposite direction. Like if you see a right side curve on the cervical area, there is a possibility of a left side curve on the lumbar area. So what happens in scoliosis? So as the spine begins to curve, the vertebral column rotates around its long axis. So when the vertebral column rotates on its long axis, it is causing the ribs in the thoracic region to become prominent. That's why the most common curve you will see is the right thoracic curve. The spine, you may see two types of curves. One is a C curve and another one is the S curve. The C curve is the most common one you will see, and you can see in this picture that where is the primary curve, and you may see the compensatory curve. But the S curve, you will see two opposite curves in opposite directions. Here is a picture of a normal spine and a scoliotic spine. You can see the normal spine is straight and the scoliotic spine is curved. The other two spinal deformities you may see commonly is kyphotic spine and lordotic spine. The kyphosis is, how do you describe it? It's like, when the children walk with the backpack, they tend to, move like bend forward. That is kind of a kyphotic spine. And the other one is lordosis. That is the exaggerated lumbar curve. We used to say that it is called like proud of pregnancy, like how the pregnant woman's spine is. So that is the lordosis of the spine. Let us look at the etiology now. It could be postural or functional causes, then the structural. It could be the congenital causes like defects in the vertebrae, acquired causes like neuromuscular disorders, idiopathic, like that's the most common form. It is no one knows why exactly it is happening. So as I said, idiopathic is the most common one, and you may see infantile scoliosis. Another one is juvenile. Then you will see adolescent. So the infantile one mostly affects the male children from birth to age 3, and the juvenile one, both sexes are equally affected between the age 4 and 10. And adolescent is the most common one, and this is most commonly seen among girls between the age of 10 and skeletal maturity. So as you know, this is their puberty stage. So this curve tends to progress significantly during puberty because their height is increasing. So as their vertebral column, the size is increasing. So as they grow, the curve tends to progress more and more. And during the pediatric physical assessments, we always see these adolescent girls with scoliosis. That's one of the most common one. But it depends upon how bad it is. Some may have a very minimal one, some may have a moderate one, some may have a severe one. So how do you assess this? You want to observe the child in underpants, standing straight with arms at side. I know it is hard to put a child in underpants, but what we usually do in a doctor's office is like you ask them, roll up their t-shirts and ask them to stand straight. Then all other tests are done in the similar way. So what you're looking at it are the shoulders in level, are the hips are in level, is the waistline uneven, is the spine curved, is one shoulder blade is more prominent than the other one, as you can see in this picture. These are the observations you will make. So after you examine the child in standing position, you will have the child bend down forward from waist with arms hanging. This is called Adam's test. So in Adam's test, you are asking the child to bend forward from waist with arms hanging, and you don't have to ask the child to touch their toes. Arms hanging, and if you can ask the child to put their palms together, that will be good. So you're again looking at, as you see in this picture, is there a difference in levels of shoulders, and is there a hump on one side of the back? So as you can see in this picture too, so you will be assessing for truncal asymmetry, uneven shoulders and hips, one-sided rib hump, and prominent scapula. This is again a picture of truncal asymmetry and the hump and the curve in the X-ray. This picture is also showing the shoulder neck asymmetry, asymmetrical scapulas, hip asymmetry, right thoracic curve, you can see in this picture, deeper creasing at the waist level. And you can see in the second picture, you can see the rib hump and hip asymmetry. So how do you diagnose it? The most common method is using a scoliometer, which is the most common one you will see in the pediatrician's office. Scoliometer is an instrument. This is to estimate the curve. So you will ask the child to bend over with palms pressed together, and then you will use the device put on the back and measure the degree of curvature. And that's the most common way of diagnosing it. And if they think it is moderate to severe scoliosis, then they will refer them for an X-ray. And X-ray and the Cobb's technique, it is called, Cobb's technique is the one measuring the angle in the X-rays. So they will view the X-ray and measure the angle between the vertebrae. So that is called the Cobb's technique, using the X-ray. So how do you treat them? It varies based on the onset of age, pattern of curve, emotional factors, like, some of the adolescents, they, if you ask them to wear a brace, they may not like it. So there are so many other variables associated with this. So how do you treat them? If the curve is less than 15 to 20 degree, you are just observing for progression and may resolve by its own. And the brace is, if the curve is between 20 and 40 degree, in a growing child will require use of a brace to prevent further progression, because as the child is growing during the pubertal stage, the curve may get worsened. So in order to avoid that, you're using the brace. And brace cannot be used for a mature patient. This is some pictures and photographs of braces and children with braces on. The non-surgical interventions are exercises, and usually the pediatricians will refer them to a physical therapist and they will do them. And the orthotics like braces to balance the curvature. The nursing interventions will include teach them about scoliosis, how this happens, is it functional, and how this can progress. And if they are on braces, teach them how to maintain the skin integrity and assist the patient to follow the treatment regimen. Like if they are prescribed for exercises and physical therapy, they need to follow those regimen. And how to wear the braces, how they need to be on it, because some of the children, they will be so embarrassed to use it. So we can tell them, you need to use it to have a better result. The surgical management is done if the curve is over 40 to 45 degrees. And this is needed because a severe scoliosis can cause compromise to the cardiac function and pulmonary functions. So the surgical management may be needed for those reasons, to maintain pulmonary function, cardiac function, and if it is severe, the patient may the child may have pain, and also the appearance, if it is too bad curve, how they look, as well as how they walk, their mobility, everything is disturbed there, and the body image is disturbed. So those patients would need surgical management. The most common surgical management is spinal fusion. This is to stabilize the spine so that we can prevent further progression. So in this surgical procedure, you will perform a grafting of one vertebrae to another, and the grafts taken from iliac crest, rib, or can use a donor bone too. And the bone grows in between the vertebrae and holds them in a straight pattern. You can see this in the next picture. You can see the picture of spinal fusion here. Look at the steel rods, which is helping to support the fusion of the vertebrae, and the bone grafts are placed to grow into the bone and fuse the vertebrae too. Let us talk about some nursing diagnosis. Actual or high risk for body image disturbance, and this body image disturbance could be an actual problem or a potential problem, otherwise known as high risk problems. And high risk for impairment of skin integrity, high risk for ineffective management of treatment regimen. And that's all about scoliosis. Now let us move on to osteoporosis. So by definition, osteoporosis is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration with a consequent increase in bone fragility and susceptibility to fracture. So basically it is saying it has low bone mass and there is minute deterioration with consequent increase in bone fragility. The bone becomes fragile and there will be susceptibility to fracture. So one term you need to know is osteopenia. What is osteopenia? It is the low bone mass. Some facts about osteoporosis. Women with hip fracture are fourfold risk of getting a second fracture. And the rate of hip fracture is 2 to 3 times higher in women than men. However, the 1-year mortality following a hip fracture is nearly twice as high for men than women. An average of 24% of hip fracture patients are above the age of 50 years, and they die in the year following their fracture. That's so weird, right? And 1 in 5 of those who were ambulatory before their hip fracture requires long-term care afterward. And at 6 months after hip fracture, only 15% can walk across a room unaided. Now let us look at the risk factors. We can look at the unmodifiable risk factors and modifiable risk factors. The unmodifiable risk factors are age over 50, being a female person, current low bone mass, menopausal women, ethnicity like Caucasian and Asians, family history of osteoporosis, being small and thin, history of fracture in a primary relative, like in a father, mother, siblings, chronic medical conditions. The modifiable factors are smoking, alcohol use, sedentary lifestyle, poor nutrition, and medications. The three most common sites of fracture you will see due to osteoporosis is spine, the vertebral fractures. Most commonly you will hear compression fractures of the spine. Those are mostly due to osteoporosis. Then fracture of the wrist, fracture of hip. We can classify osteoporosis into primary and secondary. The primary osteoporosis is due to postmenopause or age-related, and secondary is related to a chronic disease, drug therapies, and lifestyle, like a sedentary lifestyle. What are the signs and symptoms? The first one is loss of height or decrease in the height. You may hear people say that, oh, I remember him as a tall person, or I remember her as a tall person, and they look short now. This is because of osteoporosis. And progressive curvature of the spine, like kyphosis, remember I said, bending forward, lower back pain, fracture of the forearm, hips, or spine. The lab findings, you will see vitamin D deficiency. The serum 25-hydroxy vitamin D should be obtained for every individual with low bone density. So if the serum 25-hydroxy vitamin D is less than 25 nanogram per milliliters, we then call it as frank vitamin D deficiency. And if the levels are between 20 to 30, then increased risk for hip fracture. Another diagnostic measure is measuring bone mass density. So this can be done by dual energy X-ray absorptiometry, and this is one considered as the standard for measuring spine and hip bone mass density. They're it's a very high precision technique, and very short scan time and low radiation dose. So actually this bone density X-rays are done very quickly, and the patient doesn't have to stay there for a longer time. It's a very quick procedure. So another diagnostic measure is T-score. So it is the difference in standard deviation. You must have heard about standard deviation and statistics. So the difference in standard deviation in the patient's BMD compared to peak bone mass in a young adult of the same gender. So suppose if it's a female patient, you are comparing the difference in the standard deviation of that female patient's bone mass density to the peak bone mass of a young female adult. And the T-score between -1 and -2.5, which means there is osteopenia. And the T-score below -2.5, which means osteoporosis. So for each standard deviation decrease in bone mass density, the risk of fracture increases by 1.5 to 2.5 times. So who should get BMD testing or screening? Women aged 65 or over, regardless of their risk factors, and younger postmenopausal women with one or more risk factors other than being white, postmenopausal, and female. And postmenopausal women with fractures, they all need to be screened for bone mass density. So the goals of therapy for osteoporosis prevention and treatment are prevention of fractures, optimization of skeletal development and maximization of peak bone mass, prevention of age-related and secondary causes of bone bone loss, improvement of quality of life, and decreased morbidity and mortality. The prevention and treatment, let's look at the non-pharmacological calcium supplementation, vitamin D supplementation. You can also use, calcium-rich food like dietary supplementation, and exposure to sunlight also will give vitamin D. And but most of the time you may need vitamin D supplementation, because if you test most people now, almost every person have vitamin D deficiency. And change in lifestyle, exercise, fall prevention measures, and pharmacological measures are the medications which usually use are bisphosphonates, hormone replacement therapies, and the SERMs. Have you heard about SERMs? It is selective estrogen receptor modulators. It is selective estrogen receptor modulators, otherwise known as SERMs. Then another one is calcitonin, then recombinant human parathyroid hormone. The Institute of Medicine recommends 1000 milligram of calcium from all sources daily for all healthy adults under age 50, and 1200 milligram of calcium for people 50 years and older. And calcium carbonate we can use in split doses of calcium, and you can take it with food. Vitamin D supplementation is 600 international units in healthy adults under the age of 71, and 800 international units for healthy people age 71 or older. Exercise is very important. Weight bearing and strength training exercises like walking, jogging, stair climbing, dancing, weightlifting. So the recommendation is at least 40 minutes of exercise 3 to 4 times a week. Lifestyle changes, smoking cessation, and stop use of alcohol. We need to implement fall prevention measures like solutions for personal and home safety problems. A lot of falls happen at home. Avoid and discontinue medications associated with increased risk of falls and fractures in the elderly, and external hip protectors. Use of external hip protectors. The first medication we are going to discuss is bisphosphonates. You want to know about this medication? This medication inhibits the mineralization or resorption of the bone by blocking the action of osteoclast. And examples are alendronate, risendronate, ibandronate, and the third generation bisphosphonate is an example is zoledronic acid or Someta or Reclast. I have examples of bisphosphonates here with the doses mentioned here. I'm not going to ask you about the dosages in your exam, but you need to know about this medication. You need to know the adverse effects of bisphosphonates. They are nausea, abdominal pain, dyspepsia, myalgias, arthralgias, esophagitis, fatigue, osteonecrosis of the jaw. And the contraindications are history of esophageal abnormalities. Patient is unable to stand or sit upright for 30 minutes after the dose. These are very important for you to know. When you give this medication, this should be taken on empty stomach with 6 to 8 ounces of plain water, and the person should remain upright for at least 30 minutes, and the patient should receive adequate calcium and vitamin D, and regular dental exams should be done. Hormone replacement therapy is it used to be more common in the olden days. Now, because of the Women's Health Initiative, it is not the first line of treatment anymore. but the recommendation is use lowest doses that will provide benefit without risk and use for a shortest duration. The next one is Evista, that is the selective estrogen receptor modulator. They interact with estrogen receptors, and this is approved for prevention and treatment of postmenopausal osteoporosis. This is meant to increase the bone density, and the usual dose is 60 milligram orally daily. The next medication is calcitonin. It is a peptide that inhibits osteoclast activity, which increases the bone mass density at lumbar spine. The recommended dose is 100 international units daily or every other day subcutaneous or IM. Another method is 1 puff daily, 200 international units in alternating nostrils. These are 1 puff daily is the intranasal use. Adverse effects are flushing, nausea, rhinitis, epistaxis, and nasal irritation. The next one is the recombinant human parathyroid hormone, Fortea or teriparatide. This is an anabolic bone formation agent which stimulates osteoblasts. The normal dosage is 20 micrograms per day subcutaneous into the thigh or to the abdominal wall. The next medication which we want to discuss is the denosumab or monoclonal antibodies. This inhibit the proliferation and maturation of the pre-osteoclast into mature osteoclast bone resorbing cells. So this inhibits the proliferation and maturation of the pre-osteoclast into mature osteoclast bone resorbing cells. So these monoclonal antibodies are made to target and destroy only certain cells in the body. So they are more targeted. The normal dosage is 60 milligram subcutaneous every 6 months. And that's all about osteoporosis.